Hi all, welcome to the clinical shot. In the previous video, we had a good amount of discussion on SLAP tears and subjective and objective signs. So if you get a patient with SLAP tear and presenting with those signs, they must undergo further investigations to clarify the diagnosis. So there are some studies suggesting that these SLAP tears are often missed at the MRI scanning, and the best diagnostic tool for this condition would be the diagnostic arthroscopy. Now let's look at how to manage this condition. Snyder, in his classification, has graded this condition into 4 types based on its severity. In type 1, this involves from mild to moderate fraying of superior labrum, while the tendon of long head of biceps brachii being intact. So this is most commonly seen in people with atraumatic SLAP tears, and majority of people will be having these tears without any symptoms. So in this type, there is no specific intervention is required or indicated until the patient presents with certain specific symptoms of pain. In type 2, which is most common type, the superior labrum along with the tendon of long head of biceps brachii will be detached from the glenoid, and this is very commonly seen type. The type 3, which is rare type, and in this the superior labrum will be having a bucket handle tear, but the tendon of long head of biceps brachii will be intact at the glenoid. So this is, as I said, this is the rarest type. And the type 4, which is very similar to type 3, but the tendon of long head of biceps brachii will also be detached along with the superior labrum having the bucket handle tear. So once we establish the grade, the treatment algorithms like Brock-Mays LA 2016 can be used in choosing appropriate treatment method. For grade 1, the preferred treatment method is physiotherapy, followed by an arthroscopic debridement if the physiotherapy is not successful or the patient hasn't achieved the optimal outcomes. Then they have an option for going to the arthroscopic debridement. From grade 2 to grade 4, the surgical interventions are always the best. Now, without any delay, let's get into the physio management. In the physio management, we always tend to start with educating the patient about the condition and exercises and the things what to expect from the rehab program. We always couple this with analgesia from the doctor to make sure that the patient are pain-free doing their exercises. We always tend to start this with simple range of motion exercises at the early stages to get them back on track. And when we start the strengthening program, we always have to bear about 3 things in our mind with the shoulder, especially with the SLAP tears. The first is strengthening of posterior cuff muscles to make sure that they are able to handle that load. And the second is gradual reloading on tendon of long head of biceps brachii, because this is the most common key structure that gets involved and injured in the SLAP tears. And finally, the proprioception. The glenoid labrum, which plays very important role in the proprioception at the shoulder joint because it has the components of proprioception in it. So it is very important to target it as well. So for posterior cuff strengthening, it's worth trying of side lying external rotation of shoulder, face pulling and straight arm pulling. Focus on 7 to 8 repetition, 2 to 3 sets. Gradual reloading on tendon of long head of biceps brachii. It's good to go for scaption raise coupled with biceps curls and all shoulder press. Focus on 7 to 8 repetition, 2 to 3 sets. And for proprioception, go for slow and gradual plank taps and drop and catch exercises, so which are very good exercises for shoulder proprioception. So always make sure that you bring up these exercises on every other day in order to give the tendon of long head of biceps brachii plenty amount of time to rest and recover from each session. So, and also bear in mind that guide exercises to the patients which works better for them rather than depending on the traditional ones which you believe that has enough available evidence which might not well works for the patient. So better use your clinical reasons and try planning or designing your exercises according to the patient. Always go with exercises that the patients are comfortable with and that works better for them, and make sure that they are pain-free doing those exercises, so which has a very good evidence that improves the compliance to the treatment plan and brings optimal outcomes. Yeah, I hope that you find it really helpful. Save it and share it with your friend, and bye for now.